Welcome to the Neuroendocrine Cancer UK Q&A session on the subject of fertility, contraception and the menopause. This series of Q&A sessions has been created as part of the Neuroendocrine Cancer UK Virtual Patient Handbook, which is due to be released in 2023. My name is Beth and I'll be hosting these sessions with various medical experts covering a range of questions within neuroendocrine cancer care. Although I've worked with Neuroendocrine Cancer UK for a little while now, I'm not a medical professional myself, and so in many ways, I'm learning alongside you, the audience. Some of the questions I'll be asking have been taken directly from the neuroendocrine cancer community, and the focus of these sessions will be on providing useful information and advice in a concise audio-visual format. In this session, Professor Maralyn Druce will be answering a range of questions on fertility, contraception and the menopause. But firstly, let's get to know her a little better.
I'm Maralyn Druce, nice to meet you. I'm a consultant endocrinologist and Professor of Endocrine Medicine. I work at Barts and the London School of Medicine and Dentistry. And in our unit, we have a neuroendocrine tumour specialist centre. I'm also, as an endocrinologist, interested in hormonal health, and I've got some certification from the British Menopause Society with respect to women's health as well. So hopefully that covers a little bit of the kinds of things we'll be talking about.
Great. Thank you, Maralyn. So just to introduce the topic for this Q&A session, basically when we were looking through commonly asked questions from the neuroendocrine cancer community, undoubtedly the highest number of questions were on subjects of contraception, fertility and the menopause in relation to neuroendocrine cancer, which is why we felt it was so important to address these issues. So without further ado, let's jump straight to our first question. How might neuroendocrine cancer impact a patient's menstrual cycle and their fertility?
So it's a great question, but even before we answer that question, the preface to that, and indeed to any other question we're going to face here, is there's not going to be one size fits all as an answer to any of these things. And you'll know, and I know anyone with a neuroendocrine tumour will know, that neuroendocrine tumours come in all shapes and sizes, all different levels of spread. Some are start in different organs, some are secretory, some are non-secretory. Some patients will be interested in the topic after they've had a treatment that has effectively cured them. Some will be living with a chronic illness. And therefore, all of those different things will have a different impact on the answer to the question. So we'll have a think about this, but everybody's got a slightly different situation to think about. So in terms of menstrual cycle and fertility, I guess the way I'd think about it is I'd split it into four. The first thing I'd think about is the impact of the tumour itself. And that, of course, depends a little bit on where the tumour is. So, for example, if you've got a small localised tumour in the pancreas, say, that's not going to have a particular impact on your menstrual cycle. It's not really directly going to impact on your fertility. On the other hand, if you've got tumours in one or both ovaries, if they're small, it may not impact on your menstrual cycle. If they're large, or if they're also in the rest of the reproductive tract, it might. Some neuroendocrine tumours are secretory of hormones, and even if the tumour itself isn't somewhere in the reproductive tract, those hormones might impact on the hormones that control your periods. An example might be a hormone called ACTH that drives the adrenals to make cortisol, is commonly produced from, say, lung neuroendocrine tumours, causes a syndrome called Cushing's syndrome. But those high levels of cortisol can switch off the hormones that drive the periods. So under certain circumstances, there may be specific impacts, but there's not necessarily a generalized impact. So periods may well be regular, fertility may well be unimpaired. The second bit then is not the tumour itself, but the therapies that you might be on. So there's a little bit of data, and we'll come back to it, I'm sure, in further questions. There's a little bit of data about the impact of somatostatin analogues, more on sperm production than on egg release. And that comes a little bit from animal studies and a little bit from what we know about where the receptors are. rather than necessarily real life data. But we also know that stronger therapies like PRRT, where we're giving radiopeptides, or strong chemotherapy agents may well have an impact on ovarian function and then menstrual cycles and then fertility. So the therapies are one to think about. The third area where we might be concerned, I guess, about menstrual cycles and fertility is that a small proportion of neuroendocrine tumours don't happen spontaneously. They happen in the context of a genetic syndrome like MEN1, MEN2, von Hippel-Lindau. And even if the neuroendocrine tumour isn't an impact on fertility or the menstrual cycle, other elements of the syndrome might be. So in MEN1, for example, you may have a tumour, but separately from that, you may have high levels of prolactin that are interfering with the periods. So if the tumour's in the context of a syndrome, there may be separate things to think about. And then finally, and we mustn't forget, of course, that whether you've had a small tumour treated and you're cured, or you've got an advanced tumour that you're living with long term with multiple treatments, how you deal with your diagnosis, how that diagnosis impacts on you, and how that interacts with the rest of your life and the way you feel about it, can have a huge impact on sex drive and sexual function and quality of life, which of course are really closely aligned to fertility, childbearing, and all of those things. So again, it's not a specific one size fits all thing to think about, but these are all different areas that might be in your mind around menstrual cycles and fertility and having a family.
Great, thank you. So yes, basically very individualized. But I think you've covered quite a few bases there that perhaps people can kind of feel that they're related to them. Okay, so we know that, so on to the next question. We know that somatostatin analogues can help patients with neuroendocrine cancer by controlling their hormone levels, but can patients safely continue with SSAs whilst pregnant?
Good. So there's, of course, unsurprisingly, quite limited data to share with you on this topic. We mentioned just before about whether or not there is an impact on fertility with somatostatin analogues, which is anecdotal and animal-based. Lots of men have perfectly adequate sperm production despite being on somatostatin analogues. Lots of women have regular periods despite being on somatostatin analogues, but getting pregnant is one part of the thinking. What about when pregnant? Well, most of our data doesn't come from patients with neuroendocrine tumour. It mostly comes from patients with acromegaly who have growth hormone producing tumours of the pituitary, for whom somatostatin analogues are also an important treatment because they've been an important treatment for much longer. They've been proven as being useful for much longer in acromegaly than in neuroendocrine tumours. So although acromegaly is rare, we've got a longer back history to the use of these agents. Anecdotally, there are plenty of case reports demonstrating the safe use of somatostatin analogues in pregnancy in patients with acromegaly. But because of the theoretical anxieties around this, and of course, because in general, we know that somatostatin analogues do cross the placenta. So in some form they do, which means that they therefore have the potential to impact on baby's growth hormone production and baby's hormone secretion in general. And because we know that somatostatin analogues have an impact on placental function, so the way they work is they draw blood flow away from the gut, but they also draw blood flow away from the uterus and the placenta. So because they have impacts in both of those areas, although anecdotally there's often visible safety, there's a bit of anxiety about using them. So what you then do is kind of balance up your risk versus your benefit. In acromegaly, actually, it's pretty clear that patients can often go, unless they have a very large tumour, they can often go quite safely without somatostatin analogues for the duration of a pregnancy. And therefore, the tendency is to stop them. It may not be the case in neuroendocrine tumours that they are stoppable. They may be for a few months, particularly if you've got a very slow growing, low grade tumour. On the other hand, if it's being used, for example, to control a secretory syndrome, it may not be so straightforward to stop them. The data that we have is better for octreotide than it is for lanreotide, in that there's more information available. So octreotide is called, if you like, a class B drug, where there's no demonstrable problem in animal studies and there's not enough data in human studies. Whereas lanreotide gets called a class C drug, which means animal studies have shown an occasional adverse event and there's inadequate data for humans. So because of that, the general guidelines are stop if you can and if it's safe. If you can't stop, switch to a short-acting octreotide-based agent rather than lanreotide for the duration of a pregnancy. But under all circumstances, don't do any of this stuff without very close liaison with your healthcare practitioner. And because particularly if you've got carcinoid syndrome and you've got carcinoid heart disease, that in itself is a risk factor for pregnancy outcomes. It's really important, if you can, to do as much pregnancy planning in advance as possible with your healthcare practitioners, with your obstetrician, even if you're not yet pregnant, with your NET specialist, so that you can make a plan together about what's going to work best and what's going to be safest.
Okay, thank you. And do you think that there will be, I assume it's probably quite a complex area to do research on for...
It's not just NETs that this is an issue in. So you'll probably be aware that the number of drugs licensed, actually formally licensed for use in pregnancy, is minuscule. And that's because there is a general, firstly, it's difficult to do trials, but there's a general lack of appetite for setting up trials in pregnancy. They're difficult to recruit to. There are anxieties about fetal outcomes, and in general, drug companies don't do them. So we're left, therefore, with, by and large, anecdotal evidence, case reports, case series, animal data, guidelines, what we know of toxicities, and pragmatism. I don't think there are going to be big trials in this area.
Okay, yeah. So we're moving on to the topic of the menopause now. And for this question, I'd like to ask you about the impact of the menopause on neuroendocrine cancer, whether hormone replacement therapy, HRT, is safe to use if you have neuroendocrine cancer.
So it will come as no surprise, of course, that there's not a huge amount of research in this area either. We know that what happens in the menopause, in all people with the menopause, is the gradual diminution of estrogen cycles and progesterone cycles that you would normally see as part of regular periods. First, things become a little bit more unpredictable. Spikes can be higher, intervals can be shorter, and then gradually there's a diminution of estrogen down to nothing. And actually that diminution is the thing that causes the hot flushes and sweats that we're all so familiar with hearing about. Now, to an extent, unless your tumour has estrogen receptors and progesterone receptors on its surface, the presence or absence of estrogen or progesterone shouldn't make a huge difference. We know they do, for example, in breast cancer, where breast cancer is frequently estrogen receptor positive. We're not aware that for the majority of cases that this is a big issue for neuroendocrine tumours. They're not particularly estrogen driven, other than in certain circumstances. And there are occasional patients in whom it's very clear in the history that there's an estrogen drive, but for the most part, there isn't. And in any event, the hormones are disappearing at the time of menopause, so there's no suggestion that that will make things worse. What does happen, of course, is symptoms. So at the time of the menopause, that falling estrogen results in significant amounts of vasomotor symptoms. About 3/4 of women will suffer from vasomotor symptoms. About a half of women, it'll all kind of settle down. A quarter of women have persistent symptoms of that kind. That's important both for diagnostic reasons. If you are not yet diagnosed with your neuroendocrine tumour and you start developing flushing and sweating and bowel disturbance in your 40s and 50s, it's an important catch not to put it down to the menopause without thinking about this as a diagnosis. But in someone who's got a secretory neuroendocrine tumour and they're already suffering with flushing from their carcinoid syndrome, adding in the vasomotor symptoms of the estrogen withdrawal can just make things a little bit less pleasant for a while. So there's surely an impact in that regard. The other thing to remember with menopause is that for a small number of the treatments that we give for advanced neuroendocrine tumours, particularly the higher grade tumours, are pretty strong chemotherapies, including chemotherapies based on cisplatin and carboplatin. And those therapies do have an impact on fertility and ovarian function in a proportion of women, and therefore can bring on a menopause earlier than one might have anticipated. So some of those symptoms might come early in that situation. Not all women who are going through the menopause, be it induced by cancer treatments or natural, not all women require hormone replacement. It's not a requirement. At this stage in the game, it needs to be very clear that it should be given to manage symptoms. There's been lots of data, and the pendulum has swung to and fro about giving HRT for preventative reasons because of impacts on cognition or impacts on various other aspects of health, weighed up against the fact that it also comes with certain risks. So by and large, the current advice with that in mind is that you only need HRT if you are symptomatic, and if you are symptomatic with symptoms, that HRT will help. So not all of the symptoms of menopause are necessarily equally benefited by giving HRT. If, however, you do need HRT, it matters what kind of tumour you've got. Like I said earlier, for the most part, if you haven't got estrogen receptors on the surface of your tumour, there's no reason to suppose HRT is unsafe. And there's a sort of oncological division, if you like, of tumours in which we know there's a group in which actually HRT is advantageous. There are certain hematological malignancies where HRT is helpful. There's a group of tumours where HRT is neutral, and then there's a group of tumours where HRT is positively disadvantageous. For example, meningioma in the brain, certain breast cancers, hormone positive bladder cancer, stuff like that. There's no good clear data about NETs as a group. It doesn't fall into any one of those categories. It's worth asking the question about your particular tumour and your particular histology if you're thinking of embarking on HRT, but it may well not be a bar to HRT if HRT is what you need. And as ever, even if it were a bar, it's around a discussion about, do I have any residual tumour? What's my risk versus what's my benefit? How do I feel about living with my symptoms? What alternatives are there to HRT for managing my symptoms? Because there are alternatives to HRT for managing some of the menopausal symptoms. So it's all around a discussion about those things. But for the most part, it may well be safe if you need it, but worthy of a discussion.
Great, thank you. So kind of back again to the topic of contraception, but this is during treatment for neuroendocrine cancer. So when a neuroendocrine cancer patient is undergoing treatment such as chemotherapy or PRRT, is there any specific contraceptive that they should use or avoid?
So the first and most important thing is using contraception or avoiding pregnancy where you are in the middle of or are shortly after a treatment that is known to have a negative impact on a growing fetus. So that particularly applies to patients who are having chemotherapy. We know that cisplatin and etoposide are not good for a growing fetus. We know that there's negative data around, although less strong, around temozolomide. We have some uncertain data around some of the targeted agents like everolimus and sunitinib. We're not so sure. And for PRRT, we know that exposure of a fetus to radiation of any kind, not just in PRRT, is not good news for the growing baby. So the advice, therefore, is for the duration of the treatment, and in the case of PRRT, for a period of time after, it's important to use reliable contraception, or at least avoid getting pregnant. Now, it may be that at this time, sex is the last thing on your mind anyway, in which case contraception is of secondary importance, but it mustn't be ignored. What contraception you use is a personal decision. There's nothing that's specifically safe or specifically unsafe, but there are two things that you need to bear in mind. It needs to be contraception that's reliable and reliable in your hands. So the pill is known to be super reliable. It's the combined pill is the most reliable in data terms, but only if you remember to take the tablets. Condoms have a bad rap as being unreliable, but that's often because people don't use them reliably, and when they're used super reliably, the data looks much better. The coil, very reliable. The hormone releasing Mirena coil, very reliable. So reliability in your hands is important, but also palatability for you. So there's absolutely no point, for example, suggesting the coil, which we know is reliable, if you have anxieties about having one inserted. There's no point suggesting the combined oral contraceptive pill if you're a migraine sufferer. So something that's reliable in your hands, something that's palatable to you and indeed to your partner are the two most important things. For the purposes of how long to avoid pregnancy for, often people get a bit anxious about the chemotherapy agents and say things like, well, I know I'm not supposed to get pregnant when I'm having this, but actually I've been told it's going to impact on my fertility anyway. True, but don't rely on the fact that the chemotherapy might impact on your fertility as the contraception. You must use contraception as well. There are plenty of people in whom healthy babies have been born after strong chemotherapy. So don't assume it's going to do the job for you. For the PRRT, for women, it is recommended that you use contraception for during the treatment and for at least 7 months afterwards. If you are breastfeeding, you mustn't do that for 2.5 months after the therapy, at least, because radiation hangs about in the system, in the ducts, in the secretions. And for men, it's recommended to use effective contraception and don't embark on a pregnancy with your partner for at least 4 months after PRRT is all the PRRT treatments are concluded.
Okay, thank you. Yep, that was what I was going to ask, actually, the length of time. I think that's good to know as well. All right, so on to our final question and back to the topic of fertility. Do you have any information and advice on when neuroendocrine cancer patients should consider sperm banking or egg harvesting? And if a patient has impaired fertility, can they still have IVF?
Okay, so by and large, for the purposes of early stage treatment like surgery and somatostatin analogues and so forth, there's no good real reason to feel anxious about fertility unless there's a direct operation on the reproductive tract. For what you might call strong chemotherapy agents like cisplatin or carboplatin with etoposide, most oncologists would offer sperm banking and might discuss the possibility of egg harvesting or indeed IVF with embryo freezing. For PRRT, there's no good data. It is believed that, at least from the evidence that we have, that there may be an impact on fertility, particularly on spermatogenesis after PRRT, but that seems to be mostly short-lived and that reproductive function does recover. So in a sense, we're probably less good at counselling our patients around PRRT than we are when we know that there's chemotherapy involved. Nonetheless, depending on your age and life circumstances and desires for future fertility, it may still be worthy of a discussion before PRRT. I certainly wouldn't say don't
Yeah.
consider it. I think we're less good at thinking about it, and it's certainly worth considering. But I think our feelings about the likely toxicity of PRRT seem to be more temporary.
Thank you so much, Maralyn, for joining me today for this Q&A session. And for those watching, I hope that this video has been useful for you. And for those interested, this Q&A session is part of a series where I speak to various medical experts covering a range of questions within neuroendocrine cancer care. So keep an eye out for those, and thank you again, Maralyn.
No problem. Thanks very much.